Hi, my name is Brittany. I am Dr. Kim's outreach director. Amanda couldn't join us today because she has a hot date, but we'll be talking about the essence of medicine, fusion versus ACDF.
Joel, please introduce yourself.
Well, thank you very much for having me. I'm Chol Kim. I live in sunny San Diego, California, and I'm a spine surgeon. I take care of patients with neck and back problems. I try to utilize minimal invasive computer navigation techniques to try to minimize postoperative pain, bleeding, size of the incision, etc. That's kind of my area of expertise, and I'm very happy to be here with Dr. Abbasi, who is one of my heroes. In the same vein, he's always at the cutting edge of minimal invasive spine surgery. So I'm very, very glad to be here.
Well, thank you for being here. And I'm Dr. Abbasi for Essence. Today, we are going to talk about a subject that is very close to my heart. And I'm hoping that every spine surgeon has some explaining to do to his and her patient about what they are, what the advantage of one versus another. And I'm hoping that Brittany can, as well participate and ask some question about what they are, what the meaning of the word that we are using is. But more or less, when we do the surgery on the spine, which is a very complex structure, we are either doing surgery on the bone structure or on the disc structure. Most of the time, it's a combination of them both. And most of the time, I tell my patient, usually, our spine is made of bone and disc, bone and disc. And a disc is like a tire of a car that cushion the car against the road. It cushion two bones against each other. But it is more than that. It allows the bone to move in practically in different ways that enables us to move and use our spine. And it's made out of multiple segments. We have 20, we have 7 cervical spine vertebrae and disc. Actually, one less than 7 because C1, C2 doesn't have a disc. And then 12 thoracic and 5 lumbar. The combination, each of them moves a little, but the combination of individual motions allows us to move our torso or body. Now, spine is very complex. In the front, there is a big chunk of material, we call it disc. In the back, there are 2 small joints. Do you want to explain us a little spinal anatomy and explain how motion in the spine is possible and those different segments that enable us to move our spine?
Absolutely. Many of you may know that, when physicians talk about our skeleton, there's the appendicular skeleton, that's our arms and legs. And then there's the axial skeleton, which is our spinal column. And the appendicular joints are for locomotion, but the joints within our spine, the axial skeleton, is not for locomotion. It's for a combination of posture, stability, and kind of protecting the spinal cord and the nerves. That's why the joints in the spine, the disc in the spine, what we call a motion segment. So an elbow is a motion segment, but there's just one in each arm. Imagine my right arm had 6 elbows, and I'm trying to figure out which elbow is bothersome and how all those 6 elbows function together to make me work. And that's what problems in the cervical and lumbar spine are like. It's complicated not only because it's not really a normal joint, but also that it's stacked on top of each other with multiple segments. And then part of the purpose of that joint is to protect the nerves. So it's complicated, it's unique, and the discussion about joints and health and musculoskeletal health, you can't equate like an elbow joint to a C5-6 disc. So the way the spine is organized is in 3 columns. The front is the bone and the discs. We do a lot of surgeries there because that is where arthritis occurs, that's where deformity occurs, that's where instability occurs. But in addition to the front of the spine, there's the middle of the spine. The middle of the spine generally protects the spinal cord and all the nerves. And then the 3rd column is in the back. That's where a lot of the really powerful muscles attach, as well as 2 little joints in the back called the facet joints. So each joint in the body is different, but the spine has like a tripod configuration. The front is this shock absorbing disc. The back are two little joints called the facet joints. And together they kind of provide this kind of little bit of motion that allows you to move around in three-dimensional space, but not so much so that you collapse down or crumble. And we always focus on the disc because that's the biggest structure. That's a structure that wears down like the treads on your tire. And when they wear down, they can herniate out, they can create bone spurs. And oftentimes we have to basically replace that disc, remove the disc, and kind of replace it with something that basically realigns the spine. And when we talk about surgeries to do a fusion or a disc replacement, we have to take into account all these little anatomic features in order to make the best decisions. So hopefully that wasn't too complicated, but
Oh, no, but that was perfect. So it is a very complex structure. And I would say that, we are hoping most of the time that we really don't have to remove the disc completely. That sometimes, it's enough that find out if part of the disc is pushing on the nerve, sometimes and often, and you do it masterfully with the endoscope, you go and remove the part of the disc that pushing on the nerves. And then when the pressure on the nerve is gone, the pain usually subsides.
exactly.
But
I think that speaks to the following situation. You know how I said the spinal motion segments are not just the joint, but it also protects the nerve. So imagine a situation where you have a herniated disc. It's like a little rock in your shoe. And the main problem is that that little herniated disc, like a rock in your shoe, is pinching a nerve and you have sciatica or radiculopathy. And to treat that, sometimes all you need to do is remove that little rock. And that's it. That is the nerve part of it. But imagine a disc that is herniated, but it's also degenerated. And now the bones are grinding back and forth. So now you can have both problems. You can have an arthritis problem where the disc is totally incompetent and letting the bones grind back and forth. You have neck pain. Plus, you have a herniated disc, it's pinching the nerve. So sometimes you just need to go in and take out the herniated disc, and that's it. Other times you have to take out almost all of the disc, including the herniated disc, because you've got two problems. You've got both the arthritis problem and you have the pinched nerve problem. So again, it depends on the unique situation of each patient and what their problem is, what their main symptom is, and what their goals for getting back to life is.
Yeah, well, so can you explain to our people who listen to that why somebody who has spine problem would have pain in the legs or arms and hands, where obviously the disc is it's in the middle of our body in our spine. What is the mechanism of having pain that we call radiculopathy? If
Probably the closest thing to it that is a good example is if you ever hit your funny bone, hit your elbow, and you get a zinger down your arm to your little pinky, it's because the nerve, which is like a wire, goes down your arm through this little area near your elbow called the cubital tunnel, and it provides sensation to your little finger. And so when you hit your elbow may hurt, but most people feel it in their hand because you've kind of bumped a wire that's live.
Yeah.
So imagine that wire starts from your brain, goes down your spinal cord, and at each level, two little nerves come out to the right arm and the left arm to different parts. And at any one level, if you kind of pinch that nerve in the neck, you'll feel it down the arm where that nerve is innervating, sort of like when you do it in your elbow.
Yeah.
That's why it's so weird. That's why some patients will show up with no neck pain, just arm pain, numbness, weakness, or a combination thereof. And some patients will show up with both neck pain and arm pain. And some patients just show up with neck pain.
Yeah.
Those are three major different characterizations of people with spinal problems.
Now, what is it? What do you think? I think most of us, we understand the pathomechanism of what we call radiculopathy or pain going down the arm or hand and fingers and even legs and toes, is that the nerve in the spine being pushed by something. That something can be a disc that's ruptured and content push on the nerve, or it can be a bone that grows in the wrong place and so on. Now, but where does the back pain itself, what do you think where the back pain itself comes from?
Well, in my mind, there's probably two main ways. If you have a problem in your lumbar spine and you have back pain, the first way is it's just like pain from an arthritic knee or an arthritic shoulder or arthritic hip. There's not enough shock absorption between the bones, and the bones are touching and grinding back and forth, and that's just arthritis pain.
Yeah.
That's probably the most common cause. The second common cause is that the nerves that make you sense back pain goes down the spine. So if you pinch the little nerves that innervate the back muscles, you can have like a radiculopathy, but of your back muscles. It's less common, but because everything goes through a nerve. So you can have back pain due to pinched nerve of the dorsal rami, including the little nerves that go to the facet joints. And
What's
then
the
there's a
dorsal
third
rami?
group of patients that have back pain because of muscle strain, but that's topic of a separate discussion. But
So, but you just described so-called the facetogenic pain, and Brittany had a great question. What is a dorsal rami? Let me actually bring a picture of it. But Shaw, why don't you explain to us what those dorsal rami is? Because sometimes we go and burn it to make the pain go away, right?
Yep.
So,
So at every single spinal level, the spinal cord comes down and it becomes nerves. And then at each level, two nerves come out, one to the right side and one to the left side. That big nerve, we call it a nerve root. The majority of the nerve fibers go down your arm, right or left, or your leg, right or left. But small little branches of the nerve curl back and innervate the pain sensory fibers of the little joints in the back of your spine, the tendons and the muscles. And those are called the dorsal rami branch. It's just a silly name that, medical doctors come up with using Latin. It's completely forgettable, but they're little branches of the nerve that serve to basically provide pain sensation to your back. It's like a protective mechanism. So back in the olden days, it's your way of like preventing you from doing something really dumb. There's pain, slow down, take it easy. But in today's day and age, it's not like that. It's just sometimes just an overreaction. And so one of the treatments is to burn those tiny little nerves that just serve to provide pain sensation to the facet joints. And for people that have mostly facet pain from the arthritis of the facet joint, if you burn that little nerve, their pain goes away. So that's one of the treatments.
Now, I have heard the theory, Shaul, you tell me if it's what you think about that mechanically, 80% of our weight is supposed to be carried by the anterior or front segment of the spine, meaning in the disc, and 20% is supposed to be carried by the facet. The theory is that if your disc is really bad disc, it put too much stress on the facet, and the facet wear off, that they grow. We have like a facet that grows around the other facet. We call that hugging facet and so on. That lots of people say the reason the facets are bad and causing pain is because the disc is unable to provide the cushioning that put too much stress on the facet. How much truth is into that?
I think for a lot of patients, that is one of the main causes of facet pain, but not the only cause. Anything that irritates the facet joint, like anything that would irritate a knee joint or a finger joint or an elbow joint, will cause the facet joints to cause pain. Now, remember, the facet joints are way in the back. So even leaning back loads the facet joint. So imagine you have a patient where you got a little bit of excessive micro instability of a motion segment. So the disc in the front looks pretty good, but it's slightly hypermobile. The little facet joints in the back get a lot more wear and tear than normal. And eventually the cartilage in the facet joint wears out. You can get predominantly facet mediated pain through that mechanism because it's just like a knee joint. There's cartilage, and as that cartilage wears out, you'll develop arthritis pain.
So, Shaul, I'm going to tell you a personal experience that I have met a lot of academic surgeons, spine surgeon. They come and say they do not believe in discogenic pain or that it needs treatment. So from what I hear, you are not in that camp. You do believe that the bad disc itself can cause actually legitimate pain in the back that need surgical attention. Is that what, do I hear it right?
Absolutely. So I'll give you a couple of ideas. So there was a debate about discogenic back pain. I'm still surprised that this is an issue, but
it is a big issue. I still get the rant from LinkedIn warriors that you say, well,
So this debate, the person that said that was taking the position of that, yes, there is discogenic pain. All he simply said was discogenic pain, it exists. I'll tell you why. Anybody that's ever had a discitis, an infection of the disc, will know that discogenic low back pain is real.
uh-huh. Okay.
The problem is that when somebody presents with low back pain, it can be very difficult to figure out where that pain is coming from, including the disc, based on our existing technology. So what's weird about the spine is that if we can't treat something, we as spine surgeons almost kind of like default to believing that it must not exist.
Yes, yes.
But in reality, it's just that we don't have a very good treatment for discogenic low back pain. Turns out we don't even have a very good diagnostic tool to clearly identify pain from the disc. But if we did, we'd be able to take a sea of people with back pain and identify the few people where the disc is the predominant cause of pain, and then we could do very effective surgery. But because we don't have that good diagnostic test, and we actually don't have a lot of really good surgeons until recently, we had a lot of failures. So I find it interesting that spine surgeons don't believe in discogenic back pain.
Yes.
What they should really say is discogenic back pain is very difficult to treat because we have a hard time identifying which patients with low back pain have discogenic low back pain versus non-discogenic low back pain. That's the reality of the situation.
Yeah, and I'm sharing a screen here. I'm not sure if you guys are able to see that or not, which shows the spine. And I mean, Brittany might ask us, so what's the big deal? Like my aunt had a bad hip. They put a new artificial hip. She's so happy. Well, so what's going on? Why can't we not just take it like a knees and hips, elbows, shoulders? They're doing it like for 20, 30 years already, artificial disc. And what is the deal with the fusion? Why are people afraid of the fusion so much? And first of all, what is the fusion? Why are people afraid of it? And why aren't we doing like other orthopedic surgeon that doing artificial disc for other area of body all the time?
That's a really great question that I ask myself a lot. Why can we treat knee arthritis and hip arthritis so well? Because guess what? One of the best surgeries, period, of all the surgeries that we have in surgery, not just musculoskeletal surgery. I'm talking like gallbladder surgery, heart surgery. One of the most effective surgeries that we do is the hip replacement. So comparing it with the most successful surgery that we have, period, is like, how come I'm not as good of a basketball player as Michael Jordan? It's because there's not that many Michael Jordans in this world. There's not that many joints in the body that is amenable to surgery like this with a great success rate. A lot of it has to do with luck. The spine is not like that. It's a joint that when you treat it one way or the other, it doesn't respond as reliably as knee or hip surgery. And there's a variety of reasons for that. And no one really knows for sure, but here's my thinking. The first thing is that when you have spine motion segment pain, it's not just like a dumb joint with motion. It is also a neurological structure, and anything that irritates the nerves around there will also cause pain. So you're not just treating arthritis, you're treating arthritis plus a neurologic problem. Then you also have a joint that is not like, just imagine you had 5 knee joints or 5 hip joints stacked on top of each other, and you said, I have a hip problem. You'll probably say, I wonder which of those 5 hips is causing the pain, and you have to figure that out. And sometimes it's not that easy. And sometimes it's all 5 hips. Doing a 5-level hip replacement, that is like taking the risk and multiplying it by at least 5. And so there's a lot greater demand on the surgeon to be precise, to do a specific surgery, to know which level's the problem and which ones you should operate on, which ones not. So we just have, it's a much more difficult hill to climb, technically speaking and intellectually speaking. So obviously, all things being equal, our success rate will be much less than something simple like a hip replacement.
No,
that's my story. I'm sticking to it.
That's good, this story. That's a good story. Brittany, have you heard, because I have, that patients are coming and telling, oh my God, no fusion. I'm so afraid of fusion and so on. Don't put any metal in me. Have you heard that from patient or somebody?
I have, and there's a lot of comments that we get on our YouTube channel of people saying they're allergic to different metals, so then the devices can't be placed in them, or they have a problem with them and they want the device removed. So that's
Yep.
something that we
So
do hear a lot.
people are afraid of fusion.
We have
They
we have a
are.
nickname for fusion. We call it the F word.
Yeah.
No,
No one wants a fusion.
so what?
Nope.
My whole practice is about patients coming and saying, I don't want a fusion. Can you help me, Dr. Kim? Because I just so happen to be not only a minimally invasive surgeon, but because of minimally invasive techniques, I tend to treat a lot of things without fusion, where most spine surgeons would do a fusion. I still do fusions, and fusions are a really important part of our kind of treatment ability. But I try not to do a fusion either, because a fusion is irreversible and it's non-natural. But my mom had a 2-level spinal fusion. So if you think I don't believe in fusions, you have to think again. You just have to pick the right procedure for the right patient. If it's fusion, you should do the fusion and do it as well as possible. But if you can avoid a fusion, most people would want to do that.
Even better. Now,
I want to say one thing about the fusion.
Mhm.
If you fuse the elbow joint, oh my God,
yeah, that
it is disabling.
Walk like
It's
that.
Oh, I have it. My nose is itching. I need to scratch it. It's like you can't scratch your nose. So the elbow, the wrist, the shoulder, the hip, the knee, most of it are for locomotion.
Okay.
But each individual joint, like the 30 that we have in our spine, it's not for locomotion. It's for postural stability and to protect the nerves. So if you fuse one level of a disc in your neck or your back, you almost notice zero change in your range of motion because it's not like your elbow.
Absolutely. You see, that is let's dissect that. People tell me they are afraid of metal, and they're right. In the time that we used stainless steel or titanium with impurity, we did have some reaction to the metal. But in the last 20 years, where we are using like 99.999% pure titanium, I truly believe that episode of having problem is behind us, that you have a really metal allergy or metal reaction. And because things we use for the fusion, it's not a two pieces of metal rubbing on each other most of the time. I hope it's not. If your construct is solid, it's not. I don't believe that is really a valid concern anymore, because yes, we had it in the past with impurities, like they had stainless steel with chromium and the other cobalt material in that our body would react to that. But Charles, wouldn't you agree that with the titanium, I haven't even heard of a reaction to truly medically grade titanium?
Yep. I have a lot of patients that are worried about the metal breaking, having allergic reactions to the metal. But I agree with you. Number one, just turns out that in the spine, we tend to use almost all titanium. And titanium, by sheer luck, is one of those metals that the body just loves. And I'll give you an example. The best tooth in my mouth is my implant, which was put in with a titanium post screwed into my jawbone, and then a cap of what looks like my tooth put on top of that titanium cap. In fact, the use of titanium metal in musculoskeletal surgery came from the dentist literature. They found out that, oh my God, titanium and bone love each other.
Yes.
They even created a name for it. So we just happen to use up most of the metal. It's titanium. The other metal that we use is not even metal. It's a synthetic material called PEEK. That's the stuff that you see in like IV catheters and things that we've been using for years. So just turns out that in spine, we happen to use all the materials that the body likes the best or is the least worst.
And another thing that patients say a lot that Dr. Kim touched on is when he talked about, if you fused your elbow together, then your arm would just be stuck. And people think that when you get a fusion, now your back you're not going to be able to move around like you would before.
Exactly.
The motion. Then the second point was the motion. Like, I can talk about the neck. Generally, I tell my patient 50% of the motion in the neck is between the skull and the C2, And then each other disc has a 10% motion. And you're absolutely right. Number one, losing 10% motion in a regular person wouldn't really impact your daily life much. But that is if that segment has emotion, like if it's a bone on bone, that segment has no.
Exactly.
So you don't notice any different. In the lumbar spine, I would dare to say, is no different. If you are not an Olympic gymnast, if you fuse a level or two, the amount of the motion you even lose, if it was a normal disc, is minimal. But now let's come back to that. Nevertheless, why not put it something that mimic the motion? Why lose the motion? Why not put the artificial? Why did it take us so long? Even we talked about that it's a complex and so on. By what is the main problem? Why do we fuse instead of putting an artificial disc? And now finally we are coming to fusion versus artificial disc. What is the advantage of one versus another, and why did it take us so long?
I'm sure you know, but I don't know if most people know that we've been working on a artificial disc replacement device for a very, very long time. I mean, all different crazy permutations. In fact, you know who had the first artificial disc that I know of? Is John F. Kennedy. He had a round metallic ball put in the middle of the disc. That was the first motion device. And no one really knows what the problem is, but it's probably a combination of the materials that's required for an artificial disc. So in a hip joint, the cartilage is designed for being slippery, right? If you look at a lumbar disc, you don't conclude based on its design that it's for motion. It's a shock absorber. So almost all the devices that are out there look like little knee and hip replacement devices. They don't look like shock absorbers. So the whole design parameters are kind of wrong. So there's no shock absorption. You've got really crazy important structures that surround the spine. So in the front, you've got the aorta and the vena cava. In the back, you've got all the nerves. So getting to the surgical target site is kind of scary, and that makes surgery more difficult. And then two, because you don't have any shock absorption functions, those disc replacement devices tend to wear out in a different way than a hip replacement device or a knee replacement device. And so we're just now starting to understand that. And guess what happened? When we try to make a disc replacement device for the lumbar spine that acts like a shock absorber, we cannot find a material that can withstand repetitive squashing.
No,
So
that-
would a
After a while,
fusion
all the
device,
materials fall apart.
no, you know.
would a fusion device, oh, sorry.
No, go ahead,
Would
Brittany.
a fusion device be utilized like a shock absorber?
No.
No.
The fusion device basically is trying to make two bones into one bone.
Mhm. And
There's no motion, there's no shock absorption. And the reason why that works is that some of the pain is due to abnormal motion. So if you stop motion, the pain stops. That's why
No.
fusion in the right patient done well is like my mom. She went from barely being able to walk to playing legit 18 holes of golf, like driver to putter, like full course, full swing, picking up the tee from the ground.
Now, sure, you mentioned the anatomical problem to get there, to that place. Now, that is a serious thing I want to emphasize a little. You know, we see in the pictures the spine look like that and so on. When you open it up, it doesn't look like that. There are vessels, as you mentioned. It's a crowded place. There are lots of stuff there. And even though we, as surgeons, we know how to go around this stuff, and it gets even worse when you open it up. It's not like your veins are colored blue and the arteries are colored red and the nerves are yellow. It looked like this.
Yeah, it looks this. Yeah, it doesn't even look like that. That's a pretty clear picture.
Worse than that. This is worse than that because this is a cadaver. It's all clean, no blood. Everything is open. You go in a small place. You have to identify all those vital structure. You have to preserve them. what if I told you in this town, once a year, somebody, you have to go from the front, once a year, somebody dies of that surgery, at least, that we injure certain structures that are very vital. And then once you have to do all of that before you get where you need to be, which is the disc itself from the front, before you can put that artificial disc in. So just
Exactly.
getting there is a big deal. But as well, about this last July, I was in Germany. I talked to one of the pioneers of artificial disc, the person who was in charge of developing one of the earliest artificial discs, who has stopped doing artificial disc in the lumbar spine for 20 years. The conversation is in German, but I have it online for you. So people who are interested, I'm sure there's artificial intelligence that will translate it for you if you don't understand German.
Yep.
But one of the reasons they were thinking that the reason their artificial disc failed is because, as you said, like in the joint, like in the hip, you have a joint, you have a center of rotation, you put it in, and you attach the muscle, or maybe sometimes you don't even cut them. In the spine, just to get there, you have to detach lots of muscle, but once you're there, you put something in that has a fixed center of rotation, but in reality, the center of rotation in our spine is not fixed. It is more a shock absorber than a joint. Now, by putting something that has a fixed center of rotation, or a center of rotation that is not very flexible, that put a lots of stress on the facet, on the joint in the back. This biomedical studies has come out. That is the main reason why, at least the lumbar artificial disc, they didn't really perform the way we thought they will perform. And that's why many people, maybe many pioneers of the artificial disc in Germany, and that's where it's come from actually, lots of original data is from Germany, they quit doing that because you put it in, initially, it's a bigger surgery, you put it in, patient initially does well, but then after 6 months, a year, the facetogenic, the pain that's coming from the facet is killing them. And now all of a sudden, you really cannot go back where you started because you think that was bad when you first time you went there. Now you go there, everything is baked like a scar, and the vessel, that the nerve, they're indistinguishable. And going back there after a first surgery to take that thing out is an almost deadly surgery because
Yeah,
that actually,
revision surgery for lumbar disc replacements, if something bad happens and you need to go back in there, that surgery is very, very scary. And that's probably one of several reasons why there's not a lot of excitement about lumbar disc replacements. But
no,
there are a group of patients that do very well with lumbar disc replacements, probably better than they would do a fusion. I think the other problem is that, think about it, when you do a lumbar disc replacement, you have to do the replacement in somebody that has kind of almost normal anatomy, normal alignment, normal motion, no instability. But turns out most of the patients that need lumbar spine surgery, they have deformity and instability. And that's why we tend to do more fusions than disc replacements, because it's kind of like a specialty product for a very small group of patients that are relatively young, early on in the disease, but the disease is bad enough despite not having that much deformity and not that much instability to warrant a surgery of that magnitude. I would say that a lumbar disc replacement surgery is a much bigger, scarier operation than a lumbar fusion, even if done through the same approach.
and I will argue as well, Shaul, that for those people who lumbar artificial disc replacement is an option, your endoscopic decompression does so much better job than artificial disc, because now you have to have a pristine facet, meaning the joint in the back has to be good for you for artificial disc. The motion sometimes itself is a problem. So like if you have what we call spondylosis, meaning the bone is growing in the wrong places. If you have that, now bone is growing in the wrong places, and bone is hitting the bone, facets are extremely stressed, and now you keep the motion going. that is not a good candidate for fusion. Where like in the cervical spine, I can tell you that in the cervical spine, there are patients where there is a part of the disc that pushes on the nerve. The rest of it is all right. And then in that location, trying to take that piece of um, disc that pushing on the nerve requires us most of the time to take entire disc out and then we fuse. Now, instead of that, going there, taking the pressure off, but then putting something in place, that could be an option. Now, I want to share some
Yeah.
pictures.
I want to reiterate the difference. The difference between a disc replacement surgery in the lumbar spine and a disc replacement surgery in the cervical spine is huge. The cervical spine disc replacement experience has been very, very positive. And I love cervical disc replacement surgery. And the indications, the reason to do that versus a fusion is much wider than in the lumbar spine for a variety of reasons. The two main reasons is that the head is much lighter, than your torso. Your torso is from your hip joint up or from your waist up is like 2/3 of your body weight, whereas from your neck up, it's only 10%. So there's much less forces on your neck. And then two, the approach to get to the front of the neck to put in a cervical disc replacement device compared to the lumbar spine, the surgery is easy, like very easy, including if you had to do a revision, it would not be that scary. So there's a variety of reasons why cervical disc replacement is just an awesome procedure compared to a lumbar disc replacement device. But there are many issues. Like I still do slightly more cervical fusions than cervical disc replacement devices because you cannot have a deformity or instability when you do motion devices. Because if you just put in a lumbar disc replacement device in somebody that has a deformity like a kyphosis where your head's leaning forward or a segment that is hypermobile, guess what will happen to that motion segment? It will stay deformed. And if there's instability, it will remain unstable. So that's a terrible place to put in a disc replacement device. That is better treated with a fusion.
What I hear, why the reason the artificial disc in the lumbar spine and cervical spine are different is because less stress, easier approach, and that enable us as well to be able to go back again easier if you need to go there. And as well, that the artificial disc, we have, I think, more experience that for the artificial disc in the lumbar spine, you need a vascular surgeon to open it up for you. But in the neck, we surgeon, spine surgeon, are very familiar with the anatomy. We don't need another surgeon to show up and open up the space for us. But still, I hear that is whereas fusion can be done for almost anybody, artificial disc can be done on a selected group of people. Would you like to just say what we call in medicine contraindication, that patient who are not a candidate for artificial disc? You mentioned it to a good degree, like kyphosis, and we mentioned it for spondylosis when the bone is growing in the wrong places. And we talked about if the facets are really bad facet and not in a good shape, when you try to keep the motion in place, they hit each other. What other contraindication for artificial disc in the cervical spine are you aware of?
That was a pretty good description of the main contraindications, reasons why we shouldn't do a disc replacement device. So let's use the neck because remember, I love cervical disc replacement devices in the neck. And if it was up to me, that's all I would do. But obviously, that's not possible since everyone's slightly different. So a patient that shows up with a crooked neck, kyphosis, I do not recommend a disc replacement device because you cannot fix that kyphosis. And kyphosis is a really bad problem when your head is forward because your head is like a bowling ball perched up on a little broomstick, but the broomstick isn't in the middle of the bowling ball. It's way in the back. So it wants to fall forward. And that's why the back of the neck has muscles that are huge to hold it upright. Now, if you have a deformity at a motion segment, like C5, C6, this level, and you put in this replacement device, you won't be able to straighten it out. When you do a fusion, you can straighten it out, hold it in place with plate and screws, and let the bones heal in that position. So you can correct deformity, sort of like what we do for scoliosis. Less common is somebody that has hypermobility. So some people have like hyperactive joints that basically wear things down. So imagine you put in a motion device in a hypermobile segment. It's like your right front tire wobbling a little bit. It will wear out way faster than the other tires. So the failure rate of a disc replacement device in the setting of slight instability, microinstability, greatly increases the failure rate. And then there's other things. Remember, the motion segment in the spine is a tripod, the disc in the front, and two little facet joints in the back. The disc replacement device just replaces the disc, not the facet joints. So if the facet joints are painful, it's very possible that they'll continue to be painful. Now, a lot of surgeons believe, and I agree with them, that if you do a good disc replacement device in somebody that has good alignment, no instability, and relatively mild facet arthritis, just putting in the disc replacement device will unload the little facet joints, but it's a scary proposition. And then the last reason is that the disc replacement device is three pieces, right? The top plate that's metal, the bottom plate that's metal, and a mobile core in the middle. Those three pieces have to have a minimum amount of distance. So the shortest tall implant is about 5 millimeters. If you have a patient where the disc is completely collapsed, it's like 0 millimeters, and you're worried that prying that open to 5 millimeters is going to be too much distraction, like overstretching something out, you don't want to put in a disc replacement device. You just want to do a fusion with like a little short fusion device and not overstretch them out. That's an uncommon thing. I'm sure there's a few other reasons, but you can see how there's many reasons why not to do a disc replacement device.
No, and
compared to a fusion. A fusion is universal. You can treat almost everything. The disc replacement device is best for like a small proportion of patients. And it's worthwhile trying to find those patients. But if you're not that small proportion of patient, you should have a fusion because the overall results are better.
And as well, I think you mentioned it multiple times in the past that you have to be way more accurate to put that device in the right place because it's less forgiving. Like fusion, you put the fusion device a little to the right and the left, makes no difference. But the artificial disc, if you are not centered and you are not, it takes more work and you have to be way more accurate. Otherwise, the rate of failure is higher. Is that correct?
Yeah, it would be like, one of your tires is slightly out of alignment. You may not notice it at first, but like 6 months later, you'll notice like that tire is wearing out a lot faster than the other tires. If you put in a motion device asymmetrically, it will wear asymmetrically. Mm-hmm. And those kind of, abnormal motion causes more wear and tear on the implant. And increases failure rates. So when I do an ACDF, it's easy.
Yeah.
You put it in stably. If it's slightly off to one side or the other, it does not matter.
That's matter. Now,
when I do a disc replacement surgery, oh my goodness, I am literally measuring like that is 0.4 millimeters off to one side. That's not good enough. It is so. It's you have to be meticulous.
One of the big thoughts behind artificial disc is something we call adjacent segment disease, meaning that you fix one area. There are some surgeons say that if you fuse one segment, the level above and below have to work harder, and those segments they wear faster. Then the next level go bad is much higher rate. Now, I'm going to tell you that what I found in the literature is that if you have a spine problem, comparing you to a general population who doesn't have spine problem, you're going to have about 35 to 40% more likely have more spine problem. But I couldn't really find a really solid data that says you have more spine problem because we fuse one of your level. I tell to my patients, spine, that disc is like a tire of a car. You can have a good tire, Michelin tire, that's your genetic. Even the Michelin tire after 70 years of or 200,000 miles of driving goes bad, but as well how you use your tires. Do you go off-road? Do you go on sharp stones? The way you use like high athletes, they have crappy joints, not only spine, crappy joint general. Now, but if you fix a spine level like a L4-5, 3-4 and 5S1, does it wear faster because you fixed 4-5, or is it the same process that in few years later causes the other segment to go bad? I don't believe we have a right answer to that. But
I don't either.
one of the things about artificial disc is that if you put artificial disc versus fuse it, the rate of other levels go back is going to be lower. I know most of the studies say it is not lower. As a matter of fact, a Danish or Finnish study just came out a while back, and it was a controversy. In medicine, you can't find a paper for something or against something. It is like, you always can find the paper that
You
is.
know what would help us solve that problem? We operate on like 100 identical twins, but we only operate on one sibling, and then we wait for the other sibling to declare itself. Short of that, it's going to be very difficult. But here's what I think about that.
Anybody listening to that, we are looking for 100
identical twins with spine problems.
Volunteering.
Where only one patient will get treated or something.
Yeah.
Or one will get a fusion, and one will get a disc replacement.
You will laugh about that, but I had identical twins who had dysraphism of L5, meaning the back of the bone wasn't growing together. They both had grade 2 L5S1 spondylolisthesis, and they both had sacroiliac joint pain on the same side. Wow. So a lot of things is genetic, but
yes,
I will think that study would be a very hard study. But what do you think? What does the literature says about?
I totally agree with you. All right. So the first thing about adjacent level degeneration, like you've had surgery, you had a fusion of 4-5. What's what causes the level above and below to degenerate faster? I would say that the main predisposition is genetic predisposition. Like 50% of the risk is your propensity to develop adjacent level degeneration genetically. Like instead of getting, what tire did you say? A Pirelli or
Michelin.
A Michelin tire versus like a Costco tire or something.
Yeah.
If you got the Michelin tire, you probably want to develop adjacent level degeneration versus if you got some kind of cheapo tire. But besides that, there's also external factors. So theoretically, it just defies logic that if all things being equal, if you fuse 4-5 versus put a disc replacement device at 4-5 that is well placed, if I was in Vegas, I would bet that the fusion patient will develop degeneration faster than the other patient, because that is one of many parameters. So changing the biomechanical profile of the spine has to have an effect on the rest of the spine. So that's why, all things being equal, we'll always try to lean toward non-fusions. But just having the fusion doesn't mean you're going to get adjacent level degeneration, because it's dependent on genetic predisposition, the way the surgery was done, and then the alignment. And I want to throw in one last thing. I know I've been talking too much, and I'm sure you know this. When you do a fusion minimally invasively, the adjacent level degeneration rate is way lower than if you do a fusion open. And the reason is that when you do open surgery, you injure the muscles and tendons that act like the world's greatest back brace. So when you do a 4-5 fusion, it is impossible not to injure the muscle tendon complex at the level above. So now you've got a fusion, you've turned off the muscle tendon complex at the level above, and it's rocking back and forth, and there's no protection. It's just going to wear out over time. When we do a minimal invasive fusion, we specifically try not to injure the muscle tendon complex of the level above. And guess what happens? Very few, not zero, because remember, half of it is genetic predisposition. I do very few adjacent level degeneration fusions after a minimal invasive fusion. And I bet you if I asked you, Hamid, since you do everything MIS, when's the last time you had to do an adjacent level fusion on one of your MIS TLIF patients?
I'm compiling those data to publish. Currently, I think that is a small fraction. There is, but the small fraction of open surgery. And you just mentioned that this is an MRI. But Brittany, you don't notice, but I'm sure she'll notice that this is a one-level spinal fusion L4-5. In L4-5, the muscle that should look like this, look like that, because that muscle is not muscle anymore, it's scar. But what's interesting, 2 levels above it, this part of the muscle here, we call that multifidus muscle, 2 levels above it is scar, is not muscle anymore. How does it in reality look like? This is a patient of mine that in 2012, I got the open 2-level TLIF, open surgery. In 2014, I did a 1-level adjacent segment minimal invasive OLIF. And in 2015, patient has an accident. I had to broke everything. I had to take the patient. Now, a regular person would be saying, this is a beautiful, what is that ugly thing? A surgeon say, this is ugly scar. This is pristine, scarless tissue. And I didn't injure any of those muscles, and not even the muscle that go multiple segments above and below. I totally agree with you that the rate of adjacent segment is going to be lower, but I'm going to hold my peace until I have my paper peer-reviewed published. But the data is extremely promising.
That's going to be very, very important work.
Yeah, and and this is a difference between open surgery and minimal invasive surgery. It just makes sense as well that by you injuring less of a tissue, you as well injure less of a tissue of the level above and below, and that put you on a better path not to have adjacent segment disease. But now I have reviewed a lots of paper. Now we have now about papers that go even 10 years, almost 10 years for artificial disc, and it seems that the results are as good as fusion. So if the results are as good as fusion, this is good enough for me to say, why not, right? If they're as good. Now, I have a problem though. From the knees and the hips, we know after 20, 25 years, you need a replacement. You need to take that old device out, put a new one in. We don't know, obviously, like a neck is not like a hip and joint that you put your whole weight on it. The thing is, my only thing is, and I talk to my patient about that, we do not know how these devices will be and acting after 20 years, 30 years. So I just don't know how they are going to react. And I just be honest to my patient, telling them, we know that in 7 years, even up to 10 years, they're as good as fusion. And this is the advantage, this is the disadvantage. We do not know how they are going to be in 30 years. So what do you think about the long-term? And two questions, long-term results and multi-level artificial disc. If you address those two, we are a little over the time, but I want to hear your ideas about that, if you don't mind.
Yeah, I think the failure of the disc replacement devices occurs early. If it's going to not work well, you're going to find out relatively soon, like in a year or two. We don't have as much data like 20 and 30 years, but remember, like you said, in Europe, they've been doing lumbar and cervical disc replacements for many years. And if the disc replacement device doesn't fail early on, it has a pretty long track record. So I'm not horribly worried. But in the lumbar spine, if you have to go back in there and revise a lumbar disc replacement device, it is downright scary. In the cervical spine, no big deal. So I'm not too worried about the long-term efficacy or success rate, and worried about like in 20, 30 years, there's going to be a sea of people with failed disc replacement implants. I'm more worried about relatively early, 1 or 2 years, where the people that for one reason or another is not going to do well with the disc replacement device needs revision surgery. In the neck, no big deal. In the lumbar spine, would be very scary. So I pretty much send all my lumbar disc replacement patients to somebody that's all they do practically, because it's such a difficult surgery to do. And heaven forbid something happens and needs to be revised, they need to do it because they just are super subspecialized. Not so much in the cervical spine.
What about multi-level cervical spinal arthroplasty or cervical artificial disc? What's your take on that?
This is a tricky one. So let me pose it to you this way. I have a 3-level disc problem in my neck, and I need a 3-level surgery. What's worse, a 3-level fusion or a 3-level disc replacement device? Probably a 3-level fusion. The problem is that now you have to put in 3 disc replacement devices all next to each other perfectly. And it takes a very special surgeon to be able to do that reliably. So it's a toss-up. If you can do a 3-level disc replacement device really well, that would be a patient that is really well aligned. They'll probably do better than somebody that had a 3-level cervical fusion, because that's a lot to fuse. And the
Are
reason
they,
why I bring that up is that there is a surgeon in South Africa who's one of the best surgeons I've ever seen. His dad is a neurosurgeon too. And they're one of the people that like pioneered disc replacement surgery and fusion surgery. I went to South Africa and watched them. And the dad needed a 3-level surgery. And you know what the son said? If we did a 3-level fusion on my dad, he would not be a spine surgeon today.
Cool.
He did a 3-level disc replacement device,
are
but it
they
just happened to be by one of the
level?
best surgeons I've ever seen. So
Are
if
they,
you're gonna have a 3-level, go there.
Sean, are they in United States currently, are they approved for 2 and 3 levels?
There are 2-level devices approved. It will be very difficult to get an insurance company to authorize a 3-level disc replacement device.
They're
So if
off-label.
you wanted one in the US, you would have to probably do it outside of insurance because insurance will not cover it.
So in United States, to my best knowledge, few devices are approved for 2 levels, but to my best knowledge, no device has been approved for 3-level artificial disc, whereas 3-level ACDF is a very routine procedure. So
Correct.
I think something people might also want to know is what would be the difference in the recovery time of ACDF versus a fusion, and even in the lumbar spine,
That's a
if
very
you were
good question.
to.
uh, I would say my experience for the cervical spine is the same recovery kind of situation. What do you think, Sean?
I agree with you. From a practical, like real world experience standpoint, you cannot tell the difference. But mentally, there's a slight difference. When I do a fusion on somebody, I want those bones to be relatively stable so that they heal into one bone, like you're in a cast. So I don't encourage people to go crazy and do stuff. A motion device, you don't have to immobilize it. The way it's put in, it's so stable that you can start motion immediately. So
they
post-operative
should.
instructions are different, but because of the pain in your neck just from the surgery itself, almost everybody, the recovery is almost the same. But I would say that if you're a professional athlete, you will do better with a disc replacement device versus a fusion if you needed to get back to your sport early on. But that difference is relatively small. That is not an important decision parameter. Like, I'm not going to decide one or the other just because, oh, I think this one has a little bit faster recovery. That would be way down on my list.
Well, this has been so great, and we could, you and I, we could go on and on and on for a long time, but we are at the end of the episode, and I think we really covered it. I'm really proud of us being able to cover this complex stuff in just 1 hour. Now, my closing remark is that, as a patient, you have all the tools, make yourself knowledgeable. At the end of the day, every situation is different. Go out there, go read about your surgeon, go listen to your surgeon, listen to people who have experience with your surgeon. And the same surgery in one hand can be more dangerous or more complicated than in another surgeon's hand. But as a patient, you have all the tools. It's 2024, for God's sake, not 1950s. So you can make yourself knowledgeable about your patient, about your surgeon and surgery.
Let me emphasize that it's so important for people to be educated. And today, even though trying to assess like who's a good spine surgeon and who's not is still difficult, today it's way easier than even 5 years ago because the amount of information, especially through social media, is so much more abundant. So educate yourself, develop a list of questions, and maybe get 2 or 3 opinions. Because that's the other weird thing. It's amazing how few people get second opinions for spine surgery, probably because it's just too overwhelming of a topic. And it's like, how am I going to assess if 2 surgeons are any better? But do the best you can. And I have one piece of advice. There's 2 ways of making surgical decisions. The first way for a surgeon, the first way is to like look at somebody and go, what would be reasonable? Can I justify this surgery? And if I do it, will insurance cover it? And will people say, oh, that's a good reason to do surgery, right? The other way to decide on surgery is to say, what would I do if this was me or my beloved family member? That subtle perspective can be huge because what you would do for yourself and what's reasonable, especially when it comes to spine surgery, is 2 entirely different things. And I'll give you an example. both Dr. Abbasi and I know a lot of spine surgeons. How many spine surgeons do you know personally that have had a lumbar fusion or lumbar disc replacement? Either a surgeon or their immediate family member.
It
A
is-
little, not many. So when you go talk to a surgeon, I propose that you ask them the following question. You look them deep straight in the eye and you ask them, what would you do if I were you or I was your family member?
Yeah,
Sort of like when you order at a restaurant, what would you rather have? Should I get the filet or the salmon?
yeah.
You want to look at the waiter in the eye and you want them to quickly answer like, that's exactly how I decided.
That
They
is-
don't answer that, make them answer it like that.
Yep.
And if they don't have a good answer, then you probably want to find somebody that has a really definitive answer that you can trust.
And if you're
Probably the most important advice I can give.
absolutely, absolutely. And if your surgeon is offended by you getting a second opinion, that is especially a good reason to get a second opinion. So
Agreed.
yeah. So
Agreed.
it has been great. Unfortunately we have to. Every good thing comes to an end, and I thank you so much for this episode. For Essence, I'm Dr. Abbasi.
And I'm Dr. Chol Kim. And thank you, Dr. Abbasi. Keep up all the wonderful work that you're doing.
Thank you very much. Brittany, you have to close
Brittany,
it up.
thank you so much. I am Brittany. Thank you guys so much for tuning in.
Thank you very much. Have a good day. Bye-bye.